Hello, my name is Marwan Abourass. I was trained as endodontist and prosthodontist at University of Pittsburgh. I taught endodontics at University of Southern California for over 30 years. Today, I'm going to be sharing with you some of my ideas about relationship between endodontics and implant dentistry. We as surgical dentists, surgical dentistry clinicians, we all operate on the same tissue. We follow the same principles of surgical sepsis, hemostasis, etc. And therefore, I am addressing a competent surgeon, so I don't have to go back to basics. I'm going to share with you my concepts. These concepts were built on review of the implant literature, and I've been pretty much up to date with the literature and the advances in implant dentistry. Mesh, in 2005, in his textbook, stated implants to replace maxillary anterior single tooth remain one of the most difficult procedures to perform in implant dentistry. The difficulties is the lack of quality and quantity of bone available for implant placement. And that's what created the need for grafting materials, GPR, GTR procedures, and the whole industry of bone augmentation. If we trace the pathogenesis of apical periodontitis, critical size defects, it always go back to the substandard endodontic treatment, failures, and complications, and the way it was handled by a clinician. So if we look here, we see a single cone failure. Here we have no root canal, substandard post procedure. Here we have a perforation. All of these creating lesions, we call them critical size defects. And the question about these lesions, the real question, how and who is managing the endodontic treatment failure? He or she who is managing the failure will determine the difficulties that you're going to have as an implant surgeon. Here we see that we have an endodontic problem. It was handled poorly by extraction. And that was the result that we have here. So if we look at this situation, determine how we handling this resorption, how we handling this defects, whether in the canal itself or at the apical because of surgical work, we will see now the destruction of the cortical bone, and this is the end result. This is what implant dentist has to do. This is what you have to deal with. So let's look now at a situation. Of course, these are historical teaching cases. Here we have a broken instrument, was handled. The critical size defect was handled by extraction. And this is the result years later. No bone augmentation will take care, will heal, will repair this defect we have here, because apparently it is now from buccal to lingual, etc. And here we have a surgical endodontic failure. We're going to see now how we're going to handle these. This is the one with endodontic treatment and retrofill and a defect here. Here we have an overfill. How are we going to handle this situation in this case? This is how I handled it myself. This is the technique I'm going to speak about today. I did not handle it by extraction. I handled it by a technique I call Interim surgical endodontics. And that is the subject I'm going to speak about today. So the title of my presentation, it's Employing Interim Surgical Endodontics for Implant Site Preparation of Hopeless endodontically treated teeth with critical size defects. Watch the case selection: implant site preparation, hopeless tooth, endodontically treated tooth with a critical size defect. So how do we have this critical size defects? You all know that we have apical periodontitis, endodontic lesions. If these lesions are not treated properly on time, they will advance. And you can see here we have with year, 2 years, this is the policy, this is the approach, this is the philosophy of wait and see, because most of our lesions are asymptomatic, very slow in progress, and totally asymptomatic till they become infected. And then when it got infected, this is now what we have. We treated the case, and this is the result. Now we have healing. Now I'm showing you this case because it's a relevance to what I'm going to present next. So critical size defects are, you find them in the orthopedic literature. They are defects bigger than or larger than 10 millimeter in width, length, and depth. And with that, you have a loss of the cortical bone. Those lesions do not heal naturally. They need some form of intervention. In your situation, in implant dentistry, your intervention is the augmentation. In my field, I do endodontics, surgical or non-surgical. This is a critical size defect. This is the buccal of anterior zone. This is huge. You can see here we have the root apex, and this is the gutta-percha level. We treated those cases many, many years, absolutely with success. The problem, you do not see exactly the issue. You don't appreciate the depth, the extension of the lesion till you have a CBCT. Here's one in the posterior zone. Here's the root end. This is the lesion, the granulation tissue, and it connected with the maxillary sinus over here. Another case. Now, the good news that these lesions with endodontic treatment, we get this result. That is between 92 to 97% success. It's predictable. Surgically, it is between 85 to 92%. These critical size lesions you have here, this is after 2 years. This is native bone. This is the patient's own bone, dense bone, most suitable for implant dentistry. And that's really what is important today. You will see in these defects, I did not use any kind of augmentation. This is the time where we did a lot of work, either surgical or non-surgical. The surgical ones heal faster because we are removing the granulation tissue, we're removing the bacteria, and the body have a quicker chance to heal. How did it start? This is now a lesion. We have a patient, 72 years old, came to me in Pasadena, California. I was practicing there. The dentist was planning to do an implant here. The patient developed symptoms. And when the patient developed symptoms, then that he had to delay the procedure, send it to me to take care of it. I started endodontic treatment through the crown, and this is how far I was able to go as an endodontist. Total calcification. All I did was inoculation, a curettage of the apex, and then I could not even place a retrofill. The canal were calcified using magnification, methylene blue, all kinds of technology to find the foramen. There were none. So I wasn't going to go and make one. to place anything in it, and that's where I left it. I followed the patient, and I informed the patient when it finished, she will return to her dentist for implant placement. This is what we got in about a year. This is dense bone. And the beauty of this is the maxillary sinus here. This lesion, absolutely, in my opinion, has gone into the sinus at this situation, at this level. So what's my technique? Let me give you the principle. Here we have a situation. We have here a perforation, previous root canal treatment. You as a clinician, as a surgeon, it's very simple for you to raise a flap, assess situation, and do a deep epicoectomy to this level. All I need is 1-to-1 crown root ratio or less. This is going to be there only for about 8 months to a year maximum. You check the quality of the root end. If it's okay, you burnish it. If you have a problem, if you don't have a good seal there, all you do is place any kind of retrofill materials. EBA, IRM, cavet, composite. This is interim surgery. Here's a situation. We have a crack or a fracture here. I call this as a fissure. And here's the methylene blue. We're going to cut it right to that level. So what's the advantages of this technique? The advantages are many. First of all, you're going to see this case in a few minutes. Let's look at this tissue here. This is a real case which we treated. You'll see here the soft tissue. And then you see the roots. Any extraction procedure here is not going to be atraumatic. You just imagine extracting these, especially if you do not have the necessary surgical skills to do that. That's going to create a defect for this patient and many, many problems. So here what we do, we save the integrity of the soft and hard tissue, the integrity of the socket itself. And this integrity is basically the anatomy, the histology, the physiology, and the function of the area, because here I'm going to use some kind of provisional till I have the necessary healing. One of the advantages of my technique is when you raise a flap here, this is a question of the tooth. We found diagnostic surgery. We find here a fissure, a crack. Now you're going to place an implant here, okay? But with my technique, if you're not going to remove this tooth, you're going to treat it, you have an opportunity to examine the cervical zones of the neighbors, adjacent teeth, and you see there's a crack. This is comprehensive diagnosis. It's an opportunity to examine the status of adjacent teeth. And that's very important from a periodontal standpoint, from a structural standpoint, from any standpoint. It's a preventive look. Same situation here. Most of these situations we treated, and basically it is rapid elimination of the infected tissue. When you lay the flap, you remove all the problem and you get to a solid bone, and then you close. And then when it comes time to extracting the tooth and placing an implant, the extraction is so simple. This is a case actually we've done. You're going to see in a few minutes. Facilitate the atraumatic extraction of hopeless teeth and protect the adjacent structures. The maxillary sinus, the mental foramen, the incisive canal, all those areas that you are involved as an implant surgeon. Okay, with this technique, it gives you bone that is a barrier between the implant site you're going to place and the anatomical tissue in question. So now let's get two cases. This is a patient came to me with, referred to me because of the technique in Pasadena, California, San Marino, California. This tooth here had an actual fissure crack. We removed the crown, we checked the root canal. What root canal gutta-percha was excellent. We made a provisional, and then I did a simple deep epicoectomy. I removed the retrofill, got to the gutta-percha. In both of them, we burnished them under cold spray of water, and then I closed. I did not place any bone augmentation here. And this is in 6 months. This is a native bone. Here's another case, posterior. This is an interesting case because you can see this is the OBG. We have a root here, a molar, and the fistula you see here. And a root canal was done on 4 canals, the distobuccal, mesiobuccal, mesiolingual, and we have the palatal. Unfortunately, while the doctors was removing the provisional temporary, they perforated the furcation area. In few months, we have now, few weeks actually, we got a defect, what you don't see in this radiograph. No problem. I respect the palatal tissue. The palatal tissue is very hard to deal with because it's the centers of bone growth. And therefore, in this situation, we proceeded to lay a flap, and we found this defect here, huge mass of infection on the palatal. So I performed a root hemisection here. I removed the palatal root. We kept the buccal roots, okay? Then we build them up as a provisional for a while. And this is what we've done. We use this area, we made a provisional bridge, the 2 buccal roots and the bicuspid here. This is a provisional for about one year. In 1 year, we moved it and we placed 2 implants. Again, no augmentation material in this case, and we have solid bone regeneration. Now, all I want you to do is take a look. Here is this, take a look at this bone. This is in a year. The whole anatomy returned once the infection is removed physically. That's the key. As surgeons, we're doing the curettage, we're getting the area clean, and then we're closing. Another case, we did a diagnostic flap here. We found a crack in this root canal with an overfill in the sinus area. There's a lesion here mid-root, was removed. I did surgical interim endodontics over here. This is what I left. Again, in 9 months, we have total bone regeneration, extracted the tooth, actually have a tooth left, and an implant was placed. This is the case I showed you earlier. Basically, this is what we've done. The preoperative. The patient already had a root canal. Unfortunately, she did not follow up with the placement of the crown and the post, etc. It's a very classic situation in some places. And this is the canine, number 6, 7, 8, 9, 10. And this is 11. And here you have some overfill, minimal pathology here. And that is what we've done. Isolation, clean the roots from the decay, the debris, the food, whatever was inside those roots. No problem. I'm going to use them here provisionally. And we build them up with composite post. We made a provisional. Then we gone in for deep epico at the root ends and removal the overfill and doing some deep epicoectomy to the 4 maxillary anterior teeth involved. Here the case, the day of the surgery. And here it is later, about maybe 3 or 4 months. The teeth were extracted and provisional and implant placement. And this is the final. Let me now end with, again, repeating the advantages of this technique. Rapid elimination of infected tissue, preserve the integrity of the alveolar bone, promote healing of native bone, which is more suitable for implant placement, reduce the need for massive GPR or GTR, providing opportunity to examine the adjacent teeth, facilitate atraumatic extraction, and prevent the exposure of critical anatomy. Thank you for listening.